All right, greetings everyone. Thank you for joining Impact Capital Forum and Impact at Africa for our webinar examining healthcare across Sub-Saharan Africa and the impact of impact investing as it relates to the UN Sustainable Development Goals. My name is Mabinti Karoma Moore, and I'm a proud board member of Impact Capital Forum, which is a nonprofit organization based in New York and formerly called the Microfinance Club of New York City. We are a platform for thought leadership. We have events in person and virtual. We host networking opportunities for our members that include investors, students, members of academic institutions, and financial experts. We have a working group model that includes one on opportunity zones, and we're looking to launch one on impact investing across Africa. So we are pleased to co-host with our collaborators, Impact at Africa, which is a nonprofit organization based in Nairobi, Kenya. They provide ecosystem building platform to engage with investors to improve opportunities and outcomes for social entrepreneurs. So we are delighted to have this first session to kick off our webinar series. And we are delighted to have a dynamic panel of speakers. Before we officially start our webinar, I encourage everyone to use the Q&A function, which can be found at the bottom of your Zoom platform, to pose questions to the panel speakers. In addition, we encourage you to use the chat function to state your name, your affiliation, and where you're calling from. It would be great to get a sense of where everyone is based. And lastly, at the end of our webinar, we're going to send a follow-up email with a recap of today's webinar, as well as a survey to get feedback on this panel discussion and thoughts around our working group that we're looking to form in the coming months. So with that, I am delighted to really introduce our panel speakers and our dynamic moderator. We have on today's webinar, Dr. Iris Mwanza. She's the Director of Community Health, of the Community Health Roadmap. And prior to this position, she was the Executive Director of Broadreach Institute for Training and Education, also known as BRIGHT, and worked as the Deputy Director and Chief Operations Officer for the Center of Infectious Disease Research in Zambia, where she ran operations for large-scale prevention, care, and treatment programs for HIV/AIDS, tuberculosis, and cervical cancer. Before her work in global health, Iris worked at the World Bank and as a corporate lawyer in both Zambia and the US. In addition to advocating for strong community health systems, she is also passionate about conserving nature and serves as a member of the WWF US Board of Directors. With that, I am thankful to have Iris as our moderator to kick off today's webinar session.
Thank you so much, Mabinti, and a big thanks to our host, Impact at Africa and the Impact Capital Forum. Welcome, everyone. Our wonderful panelists for today are Abimbola Adebakin, the founder and CEO of Advantage Health Africa, a health tech focused on direct-to-consumer and B2B solutions for the pharmaceutical last mile. Abimbola is a certified performance technologist, a pharmacist, a business consultant, and a tech innovator. Previously, she's held many high positions, including COO of the Tony Elumelu Foundation, where her responsibilities included oversight over their $100 million entrepreneurship program. In addition, she's had an illustrious career in management consulting, working for Accenture, the World Bank, IFC, the Africa Development Bank, and many others. She currently sits on the board of Hallmark HMO. She's a trustee of the Safe Medicines Foundation, and she's on the committee of practice of the Chartered Institute of Bankers. As if that's not enough, she's also on the board of several nonprofit organizations. She's an alumna of the African Women's Entrepreneurship Cooperative and Cascador. Welcome, Abimbola.
Thank you very much, Iris.
Thank you. Thank you for joining us. Our next panelist is Nthenya Mule. She is the co-founder of Antara Health, a company focused on making quality healthcare more accessible. She has extensive experience in both healthcare and in finance and has worked in Kenya and internationally. Prior to Antara, She served as the head of finance of Avenue Healthcare, as head of business development for Chandler Corporation East Africa, and was the founding director of the Acumen Funds East Africa office. Nthenya has a degree in economics from Grinnell College and a master's in international relations from the Johns Hopkins School of Advanced International Studies, which is my alma mater too. Welcome, Nthenya.
Thank you very much, Iris.
So hopefully, I'm not sure, is Quinton with us? Well, I'll give his bio and hopefully he'll be able to join us shortly. But Quinton Zunga is the founder and CEO of RH Bupelo, a Pan-African investment company advancing healthcare in Africa through strategic investments. Previously, Quinton was a director at Bank of America Merrill Lynch and head of its debt capital market, raising over $1.5 billion. Before his time at B of A, he was the head of debt capital markets at APSA Capital, at Barclays, where he raised over $2 billion. Yes, that's billion with a B. He's a real pioneer of Africa debt capital markets, launching the first medium-term notes in Botswana, in Tanzania, in Mauritius, and Zambia, which is my home country. He's also launched municipal bonds for the city of Johannesburg and others. So let's get started by getting a quick snapshot of the COVID situation in your home countries. And then we'll embark on a deeper exploration with each of our business leaders on both the threats and opportunities presented by this terrible pandemic. Abimbola, I'm going to start with you. Please tell us, what is the COVID situation in Nigeria?
Thank you, Iris. Unfortunately, COVID, caught us napping. I think that happened in almost every country in the world. Caught us napping, but I was quite proud at a point in time that certain state governments in Nigeria, so Nigeria has a federal government and state government and local governments. So certain state governments galvanize their resources to help, first of all, to get those who were infected, in isolation and then in treatment. This we did using temporary structures because unfortunately we did not have sufficient earmarked permanent hospitals and buildings that were for such infectious diseases at the quantum that was needed. Yes, we have some, but they were not sufficient. So we had a lot of donations and contributions from banks and from large organizations to, put a fund together to help the country cope rapidly. Now, that was impressive. However, there were some parts that were not so impressive. Because there was a rush to lock down the country and try to curtail the spread, there was a rapid, there was a quick shutdown of economic activities that had huge impact and repercussions on a lot of people. Nigeria has a large population of those who live on a daily bread, so to speak. So they earn daily. And there's no significant social safety nets in place. Now, if you do that, that means you're vulnerable to anything that truncates the steady business. And we had millions of people in such a situation on lockdown. So it led to some restiveness, although we did try to observe the lockdown, to try and curtail community spread. It still led to a lot of economic impact, and then the social impact, we're still feeling it up until now. But good enough, Nigeria is a very family-oriented economy or society. So people reached out, for one another. So the support we couldn't quite get from a structured format from government, people got from family members, and that helped, and that has always helped our economy. The informal structure has also quite, responded. Right now, where we saw an upsurge late last year, we saw an introduction of new variants late last year. But because we had, tested the model of, putting people in isolation, trying to curtail community spread, that, kicked back in, and then we didn't lock down as some other economies have locked down. Instead, we've done a lot of social information regarding, preventive measures, using your mask, washing your hands, and the country has refused to go on lockdown. I think that's been a good point, because I don't think we could have survived another lockdown without social incentives.
Thank you so much, Abimbola. Sounds very much like the experience in many other African countries. And Nthenya, maybe you could please share with us your situation in Kenya.
So there's some, thank you so much, Iris. There's some similarities to, sort of the presentation that Abimbola has just presented in terms of what happened in Nigeria. So in Kenya, when the first COVID case was announced in March, the government was very quick to respond both at the national level and then, disseminate it to the county level in terms of immediate action that would be taken, and protocols were put out in terms of what was going to be happening from a social perspective. So we went straight into lockdown in Nairobi. Schools were closed. That happened very, very quickly. There was the whole, that very strong public messaging around hand washing, around social distancing, around masking. For us, in fact, there was introduction of fines for being in public without a mask. There were protocols that were introduced in terms of how public transport would be treated. So we have matatus, which are the minibuses, which are the principal public transport mechanism that is used. And you have some that are 14-seaters and others that are 25-seaters. So the government immediately released, protocols of reducing passengers per vehicle and insisting that, drivers and the turn persons who collect the fare and so forth needed to be masked at all times. And this was actually being enforced. So that messaging was very strong. And I think that did actually help. There was closure of public spaces. So churches, mosques, bars, for Kenya, that one was a big one because we are a country that believes in socializing very much at, your local, your local pub. So, and then introduction also of curfew. So the initial curfew after the first lockdown was at 7 o'clock, 7 p.m. every evening, and that would go until, 5 in the morning. So that took place very quickly. And I think the public messaging that was there in terms of the protocols that we all need to observe were taken on board, quite quickly by most Kenyans. So I think the Kenya government's response in that regard was positive and went well. Some of the things thereafter that did not go so well was, then what actual intervention was going to take place. In Kenya, there was immediate collaboration between public and private facilities. So the government, put aside monies that were supposed to go towards, public funding of things like masks, making sure that frontline staff had the correct equipment. But Kenya being Kenya, there were, incidences of shenanigans that took place where some of those funds did not get to the places that they needed to get to. I would say that overall, the collaboration between public and private sector was actually very strong and still continues to be this way. So both from a perspective of reporting in terms of cases being dealt with, and also in terms of giving guidance to the public in terms of what they needed to do. So a lot of advocacy was around, unless you are in respiratory distress, please stay at home, even if you present with, COVID symptoms. So that again was something that the government did very quickly. The other thing that the government did is that there was a reprieve in terms of the taxation system. So there was a drop in the tax, both corporate tax and pay as you earn was reduced, and value-added tax also came down. So that remained in effect until the end of 2020. But we've gone back now to the original governing regime for such things. So that's Kenya. And then, in terms of persons infected, we're standing at about just a little over 100,000 that have been reported officially, about 1,800 deaths that have occurred. And then now we're getting ready to start looking at vaccine distribution. So we're on the AstraZeneca mode. Kenya was part of the trials. 4 countries globally were part of that trial program. We were part of that. And we are anticipating that those vaccines are going to be in country between end of next week and latest mid-March. Okay, and the first wave of vaccines is going to happen by April. By the end of April, they anticipate that they will have finished. And then the second wave, that will be about 1.6 million people that will be covered by that. By the end of June, another 6 million will have been covered. And there are protocols in terms of which demographic strata are being prioritized for the vaccination. So that's where we are in Kenya.
Great, thanks, Nthenya. Just a quick question. What is the population of Kenya? Just to give it
we're 48 million.
Okay, thank you. I see Quinton has joined us. Welcome.
Hi, thank you.
We're just talking, we're just doing snapshots of what's happening we've done Nigeria, we've done Kenya, so perfect timing. Could you tell us what's happening in South Africa regarding COVID?
Yes, thank you very much, Iris. South Africa is probably got the most cases on the continent. It is had 2 waves so far, with the second one being more severe than the first. The cases have been regionalized, so certain regions have carried the highest load of infection. That second wave seemed to have passed, and we are in the early 1,000 cases per day regime. And obviously we are expecting a third wave if everything remains the same, even with the vaccination program, which started last week. We ourselves are into private healthcare. So we see a little bit of a difference between public sector and private sector, in that in public sector, you do have you cater for a certain segment that are able to pay a certain amount, whilst the public sector caters for everybody. The first wave was well managed. Second wave, we did have a full capacity in about 70% of our facilities, which was quite a bit of a challenge to manage. But I could say that the whole of South Africa hasn't seen a collapse of the healthcare system in both cases. But the second wave was a little bit harder and more difficult to manage from a resources point of view, plus managing the caseload.
Great, thank you. Thank you so much. Now we've had our snapshots from West, East, and South Africa. I'm going to return to you, Abimbola, for our deeper dive. Can you briefly explain, what does your business do, and how has this pandemic impacted it for better and for worse?
Okay, good question. So when we started in January 2017, we set out to aggregate and be, the impartial umpire, so to speak, in business relations between pharmacies and consumers. So we started then with a B2C solution that finds medication wherever, all over the country, and delivers wherever. Now that sounds so simple, and we were wondering why it hadn't been done before. Because what we met on ground was a few pharmacies were offering online pharmacy services, but there were few. You probably had 2 branches or 3 branches. Nigeria is peculiar in that it doesn't have large chains of pharmacies. Our largest chain probably has less than 60 pharmacies, and what you found then was quite a number of small players trying to play on the big field. So our aggregation of pharmacies was the first of its kind, and we aggregated almost 1,000 pharmacies, and then we're able to pick medication from any one of them and then deliver all over the country. Nigeria is vast with about 200 million people. Now that capability showed us, several other things along the value chain, and then we began to do a B2B where we're offering access to markets, access to skills, and access to resources for pharmacies across the country. We don't have enough of such pharmacies. So anything that you can do to grow the number of pharmacies and then strengthen them in their operations would help ultimately to deliver better access, affordability, and quality of healthcare to patients. Pharmacies happen to be like about 60% of the first, I mean, if you want to look for healthcare initially in Nigeria, they stand for 60% of such first level care. And therefore, they're a bit important in our primary healthcare. So my business therefore promotes something called mymedicines.com. That's our business to B2C. We also promote a franchise chain of pharmacies called My Pharmacy. And we're also now in pharmaceuticals where we're actually providing certain medicines and being the sole distributors for those medicines. We do a pharmacy benefit program for 12 health insurance companies. That way their clients, their patients are able to pick up medication from across that network. We've done a lot of intervention around, pharmaceutical consulting, just helping people in that space to think beyond being professionals, but also being business owners. So that's what we do.
So
In COVID, okay, no, so you said, how did it impact? In COVID season, it's still on, but it's eased off a bit. But in COVID season, we saw the validation of mymedicines.com. We had launched it on the 1st of October 2017, but during COVID season, the lockdown and all, we saw demand grow 5 to 6 times on a monthly basis, 5 to 6 times. I granted an interview on CNN, describing this as one of the good things, happening during that lockdown. On the flip side, we saw a lot of disruption in the pharmacy chain because there was a lot of uncertainty around movements. There were curfews. There were indirect information around who was an essential worker. You found people that were not medical doctors not being considered as essential workers. So we had staff of pharmacies not being given, the access that they needed, and we had people trekking over 60 kilometers just to get to work. So opening times and shutting down times were really disrupted, and therefore we couldn't have consistency in opening hours. Secondly, we couldn't have consistency in supplies because Nigeria is so highly import dependent. We have only about 30% of our medicines produced locally. Our dependence on India and China showed us up during the COVID period. And this, I think, reflects badly on the whole continent, how our vulnerability to external support or external supplies of medicines really showed up during that period. The third thing that happened was that where you did find materials, they were hiked. The prices were hiked, and a lot of people that were non-pharmaceutical in nature hijacked it to trade to quickly make money. So you found things that were, necessary for prevention that were being handled by mere traders, and because they had access to funds, that gave them leeway, became a free for all. It became, you buy medicines or you buy PPs, and then you hoard them until the prices went up astronomically. And then people who needed them in a panic situation really couldn't get. We saw people that were their medication for their normal routine drugs, like hydroxychloroquine, was the price went off through the roof. And we had people then skipping their medications simply to, just take something. So it really disrupted the supply chain system across Nigeria for medicines, for medical devices, and it disrupted pharmacies as traditional pharmacies. But it appeared we had been prepared for it by having an alternative omni-channel business that really went through the roof for us.
That's great, Abimbola, that you were timely in establishing your company. Not that anybody would want this terrible pandemic, but you've been able to help a lot of individuals and other businesses weather the storm. We'll undoubtedly come back to you with questions from the audience, but I'm going to flip over to Nthenya, and maybe you can tell us about your business and how this pandemic has impacted your work.
Thank you very much, Iris. So Antara Health is a concierge service that provides a virtual first healthcare service. So we are very concerned with making access to healthcare an easy thing for patients in Kenya. The Kenyan healthcare system is exceedingly fragmented. And so for many people, it's very difficult to sort of navigate proper care that's actually going to end up having net positive impact on an individual's health. So we have a channel through which patients can reach us when they have any issue pertaining to their health. We have health navigators who are the first point of call. These are trained nurses. They assess what that situation is. If they can resolve it, they do. If they need to escalate it to our virtual care doctor, then they do so. If those virtual care doctors are then able to also fully resolve that particular issue virtually, they do so as well, up to and including prescribing of medication, and then we take care of delivery of said medication to the patients. We then work in conjunction with facility providers, clinical providers who either have clinics, hospitals, or networks of clinics and hospitals. And so for those cases that require in-facility referral, we then refer it up the chain. So for us, COVID actually presented an opportunity that came right at the right time, because what we try to encourage is, as much as possible, if you don't need to go into a facility, reach out to us and we will take care of you. Obviously, with a pandemic that, is a virus that nobody knows anything about, there was and still remains a lot of misgiving around, I'm scared of going to a hospital because I don't know whether I'm going to go there and get COVID from the hospital and so on and so forth. Quite a lot of the patients that we deal with have underlying comorbidities, so are hypertensive, diabetic, and therefore, again, the sensitivity around, will I then get infection if I go into a hospital? So especially for those patients, they found our service exceedingly useful because, one, we were able to keep them on their regimen of longitudinal care without compromising the outcomes that were there. So for all of our chronic patients, right when the announcement came around that mid-March time, we galvanized and actually ensured that we got them their required maintenance drugs for like a 3-month period. As Abimbola has mentioned, we also rely on, as Kenya, we rely on a fair amount of importation of drugs, even though there is a significant manufacturing sector, pharmaceutical manufacturing sector in Kenya, but there's still a high reliance on importation. So our first intervention was to ensure that everybody had enough supply. Everyone in our network had enough supply of essential medications that they needed. And then what we then also did, which is part of our concierge service, is picked the intel of the protocols that our partner care facilities were using during COVID times, okay? And then advise the patients as such. So some of the partners that we have had created physically channels of entry into their facilities. So you had to guide the patients to tell them, when you arrive, this is what you do. This is the channel that you proceed to. Make sure you go through all of these checks before you actually walk into the hospital. We would book their appointments as we normally do. And then we continued with that continuum of care, which is basically the follow-up after somebody has been in to see a doctor as needed. We then follow up with what they need to do at home so that they don't drop off as far as adherence to their care program is concerned. We found that this actually added to the stickiness that people had to our service and an increasing interest and uptake in our service as well. So this was actually beneficial to us as a business. We were fortunate that for most of the people that we are taking care of, we did not encounter a dearth of drugs in the market. So Kenya actually maintained pretty good supply of drugs across the board. And there wasn't as much hiking of prices as far as the normal pharmaceutical sector was concerned. Where we saw that fiddling around with pricing was around the COVID testing itself. Okay, so there was testing happening in the public sector that was, that was covered under public funds, But for private facilities, in the initial phase, there was that whole idea of arbitraging and taking advantage, and therefore the tests were priced quite high, but ultimately came down. What we also noticed a change in was that there were increased prices in just even outpatient consultation pricing from what had normally been there. Because again, private facilities were then pricing in with a margin the cost of PPE that their doctors would have to use in order to attend to patients, even if they were not COVID-infected patients. So we saw that escalation in pricing happening initially, but that has stabilized to a certain extent now. And so, yeah, that was the initial impact on our business. What we are doing now is that we are expanding the conversations that we are having with additional partners. And those, now that people have seen the impact of what we do in a situation where you have a pandemic like COVID, those conversations that we are having to sort of expand our partnership networks are actually progressing a lot better, because what we're talking about now is something that people have lived and felt. Okay. And so, yes, whilst we are a new business model in terms of what we are introducing to the market, people have felt the impact of this thing of, man, what would I do if I can't, get to a facility? Who would I go to help me with my health issues? And so that solution now becomes something that is a lot more cogent in the economy here.
Thanks, Nthenya. Just a quick question. So who is your client? Is your client, if I'm an individual living in Nairobi, I can sign up, or do I have to go through an employer or an insurance company? Who is your client?
So our payers span that gamut that you've just spoken about, okay? So our principal target of clients are insurance companies, because our business basically reduces the number of in-facility visits that a person will have at any given point. The private insurance sector in Kenya is very hard hit by usage, all right? So that imbalance that is there in the system, where most Kenyans are not covered by insurance. So for a provider, what they want to do is look at every patient from an episodic perspective. And it is Christmas time if you happen to have insurance, because now I can overtreat, overbill, do all of those things, which for an insurance company then hits on their loss ratios, and they are trying to really manage that situation. So our payers are principally insurance companies, and the bulk of business for insurance companies is employers, okay? So very few individual Kenyans buy insurance out of pocket, because again, there's also a lack of knowledge, of deep knowledge in the marketplace around what insurance does for you. So most Kenyans will rely on social networks. If I get sick and I end up in hospital, what we're going to be looking at is family and friends to quickly do a fundraiser known locally as Harambe. And we even have now like the e-platforms for even doing, those crowdfunding for health, for catastrophic health events. And they get the money together. So the work that we are doing is trying to take care of those gaps that are there as a first phase. And then ultimately what we want to do is, as we build data around patient profile and so forth, is then get to a level where we're innovating on products, more appropriately priced and structured products that can go out there to take care of people's health.
Great. Thank you so much. And then I will circle back with you shortly. I want to get to Quinton. So Quinton, you're a successful investor in the health sector across Africa. What has the pandemic meant to your investor outlook?
Our investor outlook has been somewhat changed. I mean, there's been pluses and minuses. I mean, just a bit background, what we do, we are a collection of 4 private equity funds with one listed fund and one debt fund, all focused on healthcare investments. Our listed fund is listed in South Africa and on the Johannesburg Stock Exchange and on the Rwanda Stock Exchange. So we basically invest the core of our money in healthcare infrastructure but we also increasingly investing in the value chain. So what has happened is in the pandemic, our fundraising efforts have reduced. Currently, we sit with $400 million in committed capital, which was increasing at about 50 to $100 million a year. But last year, it slowed down significantly because a lot of the investors decided to focus on existing commitments and slow down on new commitments. So last year was a very slow investment capital formation year for us. On the asset level, it was mixed. Obviously, in the peak of the pandemic, we did have above budget performance of asset, but also when there was hard lockdown, it was below budget, and we only clocking our first full year in end of February and end of March. So the combination is still somewhat not clear whether it was a, we're on budget or below budget, but we do think the over budget months were much higher than the amounts we lost when we were under budget. So there's a little bit of ironic economic positivity, if I can put it that way. So it's a weird thing to make money when there's a problem. So it's always hard to explain. But we still think strategically our focus is a big Pan-African platform. We still think there's a lot of emphasis. We did get almost triple the number of reverse inquiries from international investors. So it wasn't completely no interest. It was they were firstly trying to figure out how they start to look at healthcare in Africa, and a lot of them, the opportunities have been very difficult for them to kind of understand. It's going to take them a bit of time, and yeah, so it's been a mixed bag. But overall, I think for us, the way we see it, it's a flat year. If I put all of those things in combination, I'll say it's a flat year because you're growing slower. You're probably there and thereabout on economic performance, but the overall theme which we have, which is to aggregate over $1 billion, slows down dramatically. So strategically, we kind of lost a year, but yeah. So we'll see how that goes going forward.
Thanks so much, Quinton. I think we can all probably agree that most, if not all, governments have been struggling with this public health emergency. So what do you think is the role for impact investing during a public health crisis, if any?
Yeah, so in my view, I would have thought there would be a bigger response on infrastructure. Currently, the response is on vaccination and therapeutics, but the healthcare landscape at the core hasn't changed on the continent. We still have very little, not enough infrastructure, not enough medical professions, and it's very difficult to build from the top up, because at the end of the day, one needs to go into a hospital where the standards are okay, the medication is what is legitimate or is actually genuine, and the trust level between the consumer and the medical provider is there, plus the financing system in terms of healthcare insurance are reasonable. So that hasn't changed. So what I see is impact investors need to focus on developing that chain. There's no better time than now, because we've all seen that the world is so interrelated. So one healthcare problem, one part of the continent or one part of the world will soon become a problem for everyone. And I do think everyone right now is still firefighting a little bit. So there's just too many things going on, too much drama. But I do think the opportunities post or when there's reasonable control of the pandemic are going to be much better for healthcare. I mean, historically, healthcare infrastructure is the place where people don't want to put money because it's very slow, highly capital intensive, and everyone wants to play a little bit more in the other value chains, farmer, and possibly in the financing space. So we do think this is a positive, but the effects haven't yet been felt, and the next couple of years are going to be quite telling whether impact investors are willing to take the long view of healthcare on the continent.
Yeah, very, very true. So we're going to open up to questions for our panelists. So anybody who has a question, you can either raise your hand and ask the question or pop it in the Q&A, and we will get your questions to this panel. But one of the themes that has come up a lot, I guess, in all of your discussions is really that, you know, historically, the health sector has been dominated by the public space. Now we're seeing new opportunities, and I think all of you have risen to the occasion to fill in the gaps that the public health sector is not able to fill. But do you think there's more scope, and I'll go back to you, Abimbola, do you think there's more scope for public-private collaboration, and specifically around the financing? I mean, for example, just recently, the World Bank announced a $12 billion earmark for low and middle income countries, but this money goes almost entirely to governments. Do you think there are ways in which we should be rethinking or reimagining the public-private healthcare space in Africa?
Absolutely. I think that if you look at healthcare from the normal perspective of value chain that you apply in agriculture or that you apply in oil and gas, I see healthcare as having the upstream, midstream, and downstream levels. And all levels require joint efforts, all levels require investments, both from private and from government. And all levels actually require intensive renewal as we speak right now. So depending on the kind of pockets we have, depending on the focus, there are certain things that must be done and should be done together with government. I'll give you an example upstream. Right now in Africa, we have very few companies that have invested in APIs. APIs are active pharmaceutical ingredients. Now without APIs, we cannot begin to dream, not even to implement. We cannot begin to dream of having our own local production of medication. Secondly, we need to begin to enhance proper investigation and research into our herbs. I think that herbal medicine has been given such a back seat that we're losing out. I personally believe that the cure for cancer resides in our forest, but that's my pet peeve. That's my own, pet idea. But if we invest in research the way that we have seen reinvestment over 10 years, over 15 years, and we understand that one active ingredient coming out will pay for all of that investment, certainly will be more deliberate and would have better outcomes. Thirdly, I think in drug research or clinical research, we must begin to do much more work together with government, using private facilities and government facilities to begin to test a lot of the medication in Africa on Africans so that we can have better prognosis and better treatment outcomes when we produce many of these drugs for Africa. If you go midstream, we have a lot of gaps in logistics, in packaging, a lot of gaps in the fact that we do not collaborate. If we enhance and promote technology that will enhance that interconnection, that happens midstream, and then we will have better benefits. For example, even in our clinics, right now there are many clinics that are idle, yet there are so many clinics that are filled up. that under and over, they're sitting side by side. And I'm wondering, what can we do to even out the utilization and do things that other sectors have done that we can bring into healthcare? I borrow models a lot, and I think that if we can borrow models, not just from other countries, but from other sectors, we'll probably be better off in investing in healthcare as a business. Yes, it has social impact, and overriding, definitely the social impact is overriding. But if we invest as a business, we will be able to think more pragmatically about our user interface and user experience so that people will pay for healthcare in the way they should and begin and see it less as a benefit that they look up to government and then cannot demand or make effective economic demand. I'll give you an example. If you take health insurance today, the user experience has been very poor in Nigeria. Therefore, it cannot scale until it's rebranded and reintroduced into the market. To do that, it must be a PPP. Now, health insurance probably costs about $100 to get a decent one, a basic one. But $100 is far out of anybody's reach if you don't earn maybe on a monthly basis or in good ways. And most people earn daily. Therefore, why don't we make the payment method daily or weekly or more convenient? Ultimately, you might charge even $150, but the impact on their cash flow is less. It's more convenient, and they would pay because right now they're paying much more for data, for telephony services right now than they're paying for healthcare. So I think it's a reinvention and a rewiring of our approach to payment for healthcare that is needed, and therefore we must do it jointly. There are too many public facilities that are lying fallow in Nigeria. We've got almost 3,000 primary healthcare facilities that are below par or not even working. Those facilities must be revamped before we build more hospitals. The mega hospitals are fine if you want to do a specialization, maybe a cardiac hospital, maybe a GIT hospital, maybe an oncology hospital. But for me, building a mega hospital does not solve the issues. We need to go back to the basics so that primary care, where we have more preventative, promotive, and curative work being done out of universal healthcare, can really be addressed instead of investing in a large, big hospital that has maybe 200 beds. If you go down to the primary healthcare facilities together as private, public, and maybe private equity as well, we will get more results at that level in healthcare. So just a few of my thoughts.
Thanks, Abimbola. It makes total sense. I'm going to ask you, Nthenya. You had mentioned that in Kenya there is sort of at least the potential for more public-private partnerships. Is that something that you're seeing in your business, or is that something you're actively exploring, how to engage directly with the government?
Given the stage that we're at as a business just now, it is not something that is in the immediate horizon for us. However, there are things that I think the Kenya government can do to actually enable more partnership with the private sector. So it is a fact, Kenya government does not have adequate resources to actually provide health as a public good to the entire population. So that is a fact, that stands. We surprisingly and from a positive perspective, in terms of the structure of the public health system, that cascade of referral systems all the way from your basic clinic, at the ground, dispensaries, etc., to the referral facilities is actually very well structured in Kenya. Yeah. However, the challenge always comes with management, and how do you make sure that there is actually proper management and proper partnership along all of these facilities. Where I think government can really play a crucial role that would also complement what is happening in the private sector is setting the standards for care. Okay, so earlier when I was talking about the Kenyan healthcare system being very fragmented is because there's no standard protocol across the board of care that, one, would help bring down the cost of care and would ensure that across the board we are using the most cost-effective mechanisms for treatment. Okay, So right now we are in a situation where, yes, in the public sector, there are protocols that are there. The government does have, a distribution model that lends itself to ensuring that prices are kept down. But to be fair, there isn't anything such as free healthcare, even in public facilities in Kenya, because those facilities cannot be self-funded in their current form. So I think this is where, policy direction can be given to help encourage an environment that is going to be supportive across the board. The other thing that I think needs to be there is a certain level of reduction of bureaucracy. Okay, so in Kenya, for example, we have the National Hospital Insurance Fund, which is the public sector's insurance platform pretty much for every Kenyan that is there. Okay, so there tends to be disconnect between what different arms of government are doing. So on the one hand, there is a policy directive that every Kenyan should pay into NHIF, whether through their employer or individually. Okay, but then NHIF does nothing to help me understand what my benefits as a Kenyan are. Okay, so this benefit that we're almost being beaten over the head to make sure that we are compliant on, as an individual and as a patient, I don't know what benefit comes to me. I don't know how to get that benefit when I go to a facility. Okay, so the one thing every Kenyan knows is that if I have NHIF and I am admitted into a facility that is NHIF accredited, there is a certain portion of my bed charge, whether it's a public facility or a private facility, that'll be taken care of by NHIF. But NHIF does a hell of a lot more than that. That information is not in the public domain. Okay, and the way NHIF adjudicates, the way it accredits its facilities is a minefield for anyone to understand. So even for groups that are under the same company, you will have a hospital or clinics company that, say, has 5 hospitals. The NHIF regime will be different for each one of those hospitals. So this just adds to the confusion and, and what exactly am I getting out of this? So those inefficiencies, if we could start removing them and make it easier to process for patients, I think that would be fantastic. The other thing is that also our healthcare system is designed to be a system that intervenes when there is a crisis, when there is a problem. Okay, so I think also from a policy directive perspective, if we can also start shifting so that what we're looking at is more preventive and promotive health. Okay, so in some areas, again, we've got this down pat, I would say. So Kenya has a very strong vaccination program, for example, for children. Okay, and we rank quite highly globally. So every mother knows that when I give birth to my child, this is the schedule of vaccinations that I need to have for my child and so forth. They are KEPI vaccines. They are basically, they basically cost nothing, to the mother. And there's a schedule of when my well baby clinics are happening and so on and so forth. So I think that's a great thing that has happened. But if we can have more of those regimes that are looking at preventative care, because the cost of that kind of care, the cost of promotive care is way cheaper than waiting for when the person is actually sick and now we have to go into hospital. Because even in public facilities, if you have a catastrophic event, even in a public facility, you're going into your pocket to remove money to pay. So, I think policy needs to shift so that we're actually being pragmatic around what is the economic capability of my population as a country. Okay, so again, our narrative is very similar to what Abimbola is talking about in Nigeria. Most people just don't have money. Okay, what is this education around?
I'm gonna cut you off.
Sorry,
I'm so sorry, but
no problem.
We're running out of time, and we've got a couple of questions
Sure.
that I'd love to get to. But thank you so much for your insight there. So this is a question for Quinton. What types of investment products are best suited to support African health businesses? And please explain why. So I'm picking on you, as I think this is right in your.
Yeah. So I guess you need a significant amount of equity-based funding. with long dated debt, which is structurally harder to do within the continent's capital markets because they're not deep enough. So, I mean, if you're talking about healthcare infrastructure, you need quite, patient capital, right? And unfortunately, healthcare competes for capital with telecoms, oil and gas. So the focus had not been on healthcare because there are so many other things going on the continent that could give investors a quicker return. However, one needs to understand that the African continent as a whole on a combined basis can present a very interesting business case. So if you're not looking at clustered approach, but you're looking at a very big approach, you can actually start to create the scale that you need to be able to attract that kind of capital, being patient long-term capital. So those are the instruments that are needed for finance, because currently you will find that the bulk of infrastructure is funded by predominantly donor funds and religious institutions. So that can't be right, because it really means that mainstream investors don't find it interesting enough to deploy a lot of capital, whilst billions and billions and billions are going into oil and gas. So there needs to be a shift, which I guess you can't force investors to find something attractive. There needs to be a shift in the models that we use that make scale and return. And one of them is actually looking at the continent as Sub-Saharan Africa as 600 billion people, and deciding how do you get the best models that captures, the bulk of that.
Just to push back and play devil's advocate a little bit, Quinton, I mean, the markets are, capital markets are pretty amoral. So I want to invest where I'm going to get the highest return. So if you were pitching your case or making your case, what is it that is going to pique somebody's interest? Because as you said, patient capital is a very specific, maybe niche area, but it's not something that is going to resonate that strongly with huge investment flows, at least from the little that I know. But maybe tell me, what is this? What is the story?
I think the story has to be, well, firstly, these days, obviously, the COVID is everybody kind of saying, well, health is important because it's going to affect everyone at some point. But that is not enough. It's not enough to drive the returns. What needs, so the bigger play for the kind of capital we are trying to attract is an aggregation of the continent, because it can put the kind of scale that you need. I mean, if you had $1 billion and you want to put it in healthcare, it is going to be very hard. Right now, the kind of funds that look into Africa don't look at Africa alone. They look at Africa and Asia, because the cases for just Africa alone, I mean, you're going to find family-owned hospitals, religious-owned hospital, and to drive scale in those investments is very difficult. So now you're going to have to drip feed this. So it all makes it very complex, and no one says, you know what, I'd rather take $200 million and just put it in this telco thing, and kaboom, it goes there. So it's really about networking the continent to provide bigger capital base than we are doing. What makes China drive a lot of things, and even the US so big, is that when you look at it, the capital spend quickly adds up if something makes sense, right? Which is very difficult to do within the continent because it's not yet clustered. And when it is clustered, the systems are still quite nascent. So it's a little bit of pull that we need. So you need the aggregation of the opportunity. You need the capital markets to support the whole notion. If I'm going to do a 15-year loan, I mean, the kind of markets we have make that quite a difficulty given the volatility of our exchanges. So it is something that everyone needs to work on. And I guess that's where once we crack that, we will get much more capital flows in a whole lot more sectors on the continent. But that where the issue is with healthcare.
Thanks, Quinton. It's hard to believe, but we are already over time. So hopefully I'm going to ask everyone to stick around for a few more minutes as I ask each of the panelists, and maybe we can focus on this theme of scale. So with your parting and final thoughts and some pearls of wisdom for our amazing audience, maybe you could talk about, how you're planning, Abimbola and Nthenya, to hopefully expand your businesses across not just your countries, Nigeria and Kenya, but whether you are talking about regional or Pan-African ambitions.
Absolutely. It's even in our name. So it's Advantage Health Africa. It's in our core values. The last A is Africa. We must think Africa-wide. That's the map that I wake up to every day is the map of Africa. That way, we then have a large market and a large base. I think there are a lot of similarities, whether you're Francophone or Anglophone, a lot of similarities in our health challenges. And therefore, there's a room for scale and reproducibility. We're franchising now, and we've been in talks with some people in Uganda, Kenya, Ghana, and Burundi. And for me, it would be a personal joy if before I end this, because I'm giving myself 10 years to work on this, to aggregate 5,000 more pharmacies in addition in these 4 countries, and then scale it up much further. Well, aggregating the pharmacies is a lot of work. They think mom and pop, and you want them to think corporate. So it's a bit of patient work that has to be done, and that we'll keep doing. We're glad that we have investors, angel investors that, think that, look, it's something that should be done, and you seem to be doing the grind work, the dirty work at the bottom. But we're also glad that our B2C is working and it needs scaling. And if it can scale in Nigeria, it can scale anywhere. People need medicines. They go to 3, 4, 5 pharmacies. They can't find it. No pharmacy covers the whole of the stock or the inventory that you need. Therefore, being able to pick up from one in a remote area and bring to you in your home, your office, or even in the hospital. We supply to people in hospitals. Today, we've got a COVID patient in the isolation center, and his wife is ordering medication from us since yesterday. That is what is happening, but we need to do more of it. We're looking forward to more openness and more technologies that actually can give us online real-time view of people's inventory, because there are too many standalone businesses in healthcare. If they open up to the technology, then we're happy to put that in. So yes, definitely, Africa is in our view, and anyone that can work with us to do this across Africa, is in for a good thing.
Great. I wish you so much luck, Abimbola. Nthenya, maybe you could tell us a little bit about your plans for world domination.
Okay, I'm not sure about world. We'll get there eventually, but let's just conquer Africa first, and we'll be happy with that. So the way we are looking at engagement is initially using technology to help us pull data that allows us to understand how the marketplace in which we're in is operating. And then we're also looking at partners who themselves have a regional footprint, so that as a first step, we use that as a mechanism for piggybacking into adjacent markets. And then the other thing that we're very, as I said earlier, very, very keen on is making sure that whatever we're learning that is applicable in another market, we immediately bring to bear through innovation and service and product development. So really, that is our strategy for growth and for getting, ultimately getting into the wider wider market in Africa.
Thank you so much. I really wish we had more time, but unfortunately our session is almost up, and I must hand the reins back to our hosts, Mabinti and Kwame.